name's Steve Dungy. I'm a senior consultant in emergency medicine at the Royal Perth Hospital. This is 5 on Friday, and I've been asked to talk about syncope. Syncope, as we all know, is another name for fainting. And in our clinical practice, either pre-hospital or in the hospital, we see a lot of these patients. We know that there are lots of causes, but the final common pathway of syncope is that for a moment in time, there's inadequate blood getting to the brain, and the brain shuts down and switches off, leading to a temporary loss of postural tone. The person will collapse and hit the floor. There's rapid recovery, and there's no neurologic sequelae. What it feels like to a person who's fainting is they have a short period of nausea, sweating, feeling like they're going to faint, and then a lot of people describe a narrowing in or coning in of vision. From the outside, what it looks like is that a person becomes pale, sweaty. If you're taking their pulse rate slows down and is difficult to palpate as the blood pressure falls. There'll be a temporary falling to the floor, a rapid recovery, but no neurologic sequelae. And what you may notice is the person give the odd myoclonic twitch or jerk, which is a feature of fainting, but it's not seizure activity. It's called myoclonic jerking, and it's totally different to a seizure in that people recover quickly. There's no postictal period at all. So that's what it feels like, and that's what it looks like. What are the causes? Well, there's zillions of causes. A lot of them are fairly benign. The young soldier standing on parade in the hot sun, whose blood slowly pools in his legs. The person who's phobic about having needles, the person who doesn't like coming to hospitals and responds badly to the smells. And in those emotional circumstances, because of the connection between the brain, emotion, and the vagus nerve slowing down the heartbeat and lowering blood pressure. But in simple pathological terms, there's problems often with fluid, with the pump, or with obstruction. So if a person's dry because of blood loss, or diarrhea or dehydration, that can lead to a faint. And obviously things like a ruptured ectopic or an aneurysm can be a cause. It can be pump failure because of heart failure or an infarct, a heart beating too slow or too fast. It can be because of obstruction to blood flow, like you get with a pulmonary embolism. And it can be things that affect more than one part of the system, like medications for blood pressure that are both slowing the heart down and reducing peripheral tone. There's a special subset of patients, the older patients, and people over 70 faint more often than young people do, but sometimes in that group they're fainting because their heart's just not working as well as it used to. And in fact, in that group of people over 70 who have a faint and have got known heart failure, about 50% are dead within a year, so they're an area of concern. Our approach is to take a history, examine the patient, and investigate as appropriate, trying to find a cause we can treat. But not every patient you can find a cause for, and so in that group who you haven't found a cause, the next question is, can I work out whether this patient's safe to discharge or not? Because some people won't be. The history, obviously we're looking for clues for the kind of stuff we've already spoken about. The examination likewise. And investigations, it depends very much what you've found with the history and examination. But the one comment I would make is every single person that's had a faint needs an ECG as a baseline test. And the rest of the investigations depend on what you turn up. As regards the other group, the big group where you haven't found a cause, you can apply a thing called a syncope rule, and they're downloadable on phones. So one of them is called the San Francisco syncope rule. It's essentially looking for evidence of blood loss or patients with older age and heart failure, because those people have a higher risk of turning up dead. A couple of things to add, just as by the bys. TIA and stroke are not a cause of syncope. People often put it down as being on the list, but unless it's your brain stem that's been affected, or you've had a subarachnoid or a big bleed, little TIAs don't tend to cause syncope, and we should probably put it out of our mind. In summary then, syncope is often benign. We often don't find a cause, but we need to look for bad causes. If we can't find them, we can apply a simple rule to work out whether the patient's at risk, and every single person needs to have an ECG.